So hello everyone. Today we are going to discuss is the Pontics. So what is a Pontic? Remember Pontic can be defined as artificial tooth on fixed partial denture that replace a missing tooth. So suppose this one is the missing tooth. Hello everyone. Our today's topic is about the Pontics. So what is Pontic? Pontic, it is the part of FPD that replaces the missing tooth. So suppose this one is the missing tooth and we replace it with the artificial one. So this is the Pontic. So Pontic is an artificial tooth on fixed partial denture that replaces a missing tooth, restore the function and usually fills the space previously that was occupied by the natural tooth. So what is Pontic? Pontic, it is an artificial tooth on fixed partial denture that replaces a missing tooth, restore its function and usually occupies the space previously filled by natural teeth. Now what are the ideal requirement of the, so this one is the definition according to the GPT and Tillman about the Pontics. Now what are the ideal requirement of Pontic? The Pontic, first of all, it should restore the function of the replaced tooth. It should restore the function of replaced tooth. Second, it should provide a good aesthetic. So there should be a good aesthetics. Be comfortable for the patient. It should be comfortable for the patient. It should be biocompatible, avoiding the tissue impingement or reaction. Third, it permits effective oral hygiene. It preserves the underlying mucosa and bone, preventing ulceration and resorption of the residual alveolar ridge. So lift the ideal requirement of Pontic. It includes the restoring function, providing good aesthetic, ensuring the patient comfort, being biocompatible, permitting effective oral hygiene, and preserving the underlying mucosa and the bone. So the success of the FPD largely depend upon the proper design of the Pontic. A well-designed Pontic should effectively restore both the function and aesthetics. The tooth it replaces. Now what are the factors that will affect the Pontic design? First of all is the space available. The available space should be adequate for well-designed Pontic. If teeth have drifted into space, adjustment may be necessary. Second, residual ridge contour, a smooth rounded ridge, it is ideal for Pontic placement. Hyperplastic tissue may require surgical excision. Third is the occlusal load. The Pontic must be designed to withstand the occlusal forces and replicate the occlusal pattern of the replaced tooth. Now what are the three major factors that affect the Pontic design? They are the Pontic space available, residual ridge contour and the anticipated occlusal load. So suppose when a tooth is lost, the neighboring tooth may drift or tilt into the edentulous space over the time. So that can lead to misalignment and create complication in prosthetic design and function. So drifting and tilting can compromise the space available for the Pontic, making it difficult to place a pontic that restore both aesthetic and function effectively. So if the pontic space is reduced due to movement of the adjacent teeth, that can lead a reduced space can affect the pontic contour, compromising the appearance and hygiene maintenance. So reduced space may lead to difficulty in achieving ideal pontic design. So there can be difficulty in fabricating the pontic. Second is the ridge contour. So for resorbed ridges, augmentation process or tissue graft may be needed before the pontic placement. So, loss of residual ridge height or width can lead to gaps or open impression between the pontic and adjacent natural tooth. So these open spaces, they are often known as plaque triangles. Due to their appearance, which can significantly affect the aesthetic of prosthesis, plaque triangle can be source of patient dissatisfaction due to their visibility, especially in the anterior region where aesthetics is concerned. The presence of plaque triangles or open spaces can create areas where food particles they become trapped. Food impaction in these areas can lead to discomfort, irritation, and increased risk of periodontal diseases. Managing food impaction is important for maintaining oral hygiene and longevity of the prosthesis. Inadequate ridge contour can result in gap between the pontic and gingiva, leading to percolation of saliva or leakage of saliva during the speech. So this one is about the Sebert's classification of residual ridge deformation. Class 1, when there is loss of faciolingual, that is buccolingual tissue width with the normal ridge height. So in this type of defect, the ridge has undergone resorption in horizontal direction, leading to reduction in width but maintaining its original height. Class 2 defect. Class 2 defect when there is loss of ridge height with normal ridge width. Defect involves vertical tissue loss resulting in reduction of ridge height, while the buccolingual width it remains intact. The loss of height can lead to unsightly black triangles and difficulty in achieving an ideal emergence profile for the pontic. The class 3 defect, it is the combination of the losses of the ridge height and width. So class 3 defect, they are the most severe and involves both the vertical and horizontal resorption of ridge that lead to significant tissue loss in both the dimensions. So class 1 is loss of width with normal height, class 2 is loss of height with normal width, class 3 is loss of both height and width. Other is the roll technique. So this one is the roll technique for soft tissue ridge augmentation. The roll technique, it's a surgical procedure used to augment the soft tissue in area where has been loss of alveolar ridge contour. So it is indicated in class 1 ridge defect where there is loss of buccolingual width with normal ridge height, especially in the anterior maxilla where soft tissue aesthetics they are important. Partial thickness flap is created on the palatal or lingual surface of edentular space. There is flap elevation. The mobilized flap is then rolled or folded underneath itself and positioned over the area of the buccal defect. So the rolled tissue It serves to augment the thickness of the buccal soft tissue, resulting in restoring the contour and fullness of the ridge. So, suturing is done and healing process, healing phase that can be going to occur. Other method is the pouch technique. The pouch technique is another surgical method that is used for soft tissue augmentation, particularly in cases where there is need to increase the thickness and contour of the alveolar ridge to improve the aesthetics and function. It is indicated in class 1 and class 2 defect, specifically used for augmenting soft tissue in case where there is a need to increase the thickness or height of the ridge. So it is beneficial in anterior region where soft tissue aesthetics they are important. So incision is made along the edentulous ridge. So incision is kept as small as possible to minimize the tissue trauma and promote quicker healing. A pouch is then carefully created by blunt dissection. The pouch is extended horizontally and vertically to accommodate the graft material. The pouch is filled with graft material which may be autogenous soft tissue graft, example a connective tissue graft, allograft, or it can be a xenograft. So the graft is positioned within the pouch in way it augments the ridge contour, increasing the thickness or height as required. The incision is then closed with fine sutures and healing process that can occur. So these are the various various allograft material that we can use. Allograft material they provide a scaffold that promote bone regeneration and maintain the ridge dimension. We can use is hydroxyapatite. It is calcium phosphate material that is highly biocompatible and osteoconductive. We can use is tricalcium phosphate or freezed dried bone, or we can use so these three allograft material that can be used. So during the extraction process, the clinical may pack the socket with one or more grafting material to maintain the height and the width. So how do the occlusal load influence the design of Pontic? Occlusal load influences the selection of material and occlusal design of the Pontic. It should replicate the occlusion pattern of replaced tooth to restore proper function. Now classification of Pontics. Pontics can be classified based upon the mucosal contact. It can be ridge lap, modified ridge lap, ovate, conical Pontic, or with no mucosal contact. That can be sanitary or modified Pontic. Depending upon the shape of surface contacting the ridge, we can classify it as sanitary, modified sanitary, spheroid, saddle, ridge lap, modified ridge lap, or ovate Pontic. Or method of fabrication, it can be custom made Pontic or prefabricated like true Pontic, interchangeable Pontic, sanitary Pontic, pin facing Pontic, modified pin facing Pontic, reverse pin facing Pontic, harmony Pontic, porcelain fused to metal Pontic, or prefabricated customized Pontic. Based on aesthetic and oral hygiene, we can classify it as anterior region or posterior region Pontic. So prefabricated Pontics, they can be either true Pontics. True Pontics, remember it has a horizontal slot. So they are ready-made porcelain Pontics that it has a horizontal tubular float on lingual surface. Other is interchangeable Pontics. It features a vertical slot on the flat lingual surface secured with a lug. The third is the sanitary facing Pontic. It has a flat occlusal surface and slot on the proximal side to fit into the metal projection. Other is pin facing, a flat facing with the two horizontal pins for the retention. Other is modified pin facing. A reverse pin facing. Porcelain fused to metal facing Pontics. Pontics convex gingival surface having pinpoint tissue contact to backing occlusally with the retentive pins. Or harmony Pontics. So what are the two main types of Pontics based upon the method of fabrication? The two main Pontics are custom made Pontics and prefabricated Pontics. So why might a dentist choose a custom made Pontics over prefabricated? A custom made Pontic is chosen for superior aesthetic and ability to tailor the design to the patient's specific needs, though it is more labor intensive to fabricate. So what are true Pontics? True Pontics are prefabricated Pontics with large gingival bulk indicated for cases with limited inter-arch distance. Based upon the mucosal contact, Pontics can be saddle Pontic. The Pontic design is considered as the least hygienic because it has a broad concave surface that contacts the underlying gingiva. The saddle Pontics is considered as least hygienic. So least hygienic Pontic is, the answer is sanitary Pontics. The saddle Pontics, because it has broad concave area that contacts the underlying gingiva extensively and can create areas where plaque and food particles can accumulate. Other Pontics are spheroidal and bullet Pontics. They have shape that minimize the contact with the gingiva, making them easier to clean. Other is the ridge lap Pontics. So remember this table. The ridge lap, it is resembles a natural tooth and is avoided due to maintainable tissue inflammation. Other is modified ridge lap. This one is modified ridge lap. It is It is suitable choice for high aesthetic demands in the upper anterior region. It has a better aesthetics than the saddle ridge lap pontics by reducing the visibility and providing more natural appearance. Ovate pontics. Ovate pontics. It is used for defective or healing ridges. It offers excellent aesthetic by appearing to emerge naturally from the ridge. What is saddle pontic? Saddle pontic has a concave gingival surface that overlaps the ridges, and it is avoided because it is difficult to maintain and tends to accumulate food debris. Conical pontic. This pontic offers a convex surface making contact with the tissue at single point without exerting pressure. So it is easy to clean and maintain. Poor aesthetic due to wide embrasures, replacement of mandibular posterior teeth where aesthetics are not of major concern. Other pontics can be spheroidal pontics. These pontics contact the tissue both buccolingually, mesodistally at the ridge crest without concave gingival margins. Spheroidal pontics, they are indicated in cases with reduced interarch space where the strength of prosthesis is concerned. Other is sanitary pontics. These pontics, they have a zero tissue contact, making them easy to clean through, highly unaesthetic. So that is why they are used in posterior teeth where aesthetics are of less concern. So remember this table, conically pontics, they are used in molar without aesthetic requirement. They have a good aesthetic, good access for oral hygiene, and they have disadvantages that are poor in aesthetics. Uses indication in posterior areas. So remember these, the table. Why are the sanitary pontics not recommended for anterior teeth? Because they are highly unaesthetic, making them unsuitable for anterior teeth where aesthetics they are involved. Now classification based upon the material. We can classify the pontics based upon their material. They can be metal ceramic pontic. They are biocompatible. Aesthetics. Straightforward to fabricate. They are most indicated in most situations and contraindicated in long span bridges. Other is resin veneered pontics. They have a lower strength, poor abrasion resistance, staining, and poor aesthetics. They are indicated in long-term provision restorations, contraindicated in definitive restorations, or they can be fiber reinforced composite resin pontics or all metal pontics. The all metal pontics, they have a high strength, simple procedure, poor aesthetics, permeable to fluids, indicated in mandibular molars, especially under high stress situation where aesthetics are important. All ceramic pontic, they are highly aesthetic, biocompatible, impervious to oral fluids, poor strength, increase the risk of debonding, expensive luting agent required, anterior teeth replacement with short span bridges, molar teeth replacement, bruxism, and they are contraindicated in long span bridges. Why are all ceramic pontics preferred for anterior teeth? Due to their aesthetic value and biocompatibility. Other pontics can be prefabricated pontics or custom made pontics. The custom made pontics are fabricated individually for each patient. A wax pattern is prepared and then cast to create the pontics. So, why are custom made pontics? What are custom made pontics? Custom made pontics are individually fabricated for each patient. Prefabricated pontics are commercially available as porcelain pontics, which are adjusted according to the individual needs.